Good morning, everyone. My clinical seminar for my seminar for today is a clinical approach to myopathy. My moderator is Dr. Sruthi ma'am. Uh, Introduction: Disease of the skeletal muscles are rare and extremely heterogeneous in etiology, but manifest with a limited spectrum of signs and symptoms. Muscle disease share symptoms and clinical findings with other neuromuscular disorders such as myasthenic syndromes or motor axonopathies. Additionally, some of the muscle diseases can result from a pathogenic variant in genes that can lead to either myopathy, polyneuropathy, or in isolation or in combination. One example of such is HSPB8 gene pathogenic variant, which are associated with rimmed vacuolar myopathy and myofibrillar pathology related to the muscle disorders, whereas Charcot-Marie-Tooth disease and distal hereditary motor neuronopathy in the neuropathies. Coming to certain terminologies used in the muscle disorders, myopathy simply means it's referred to the abnormalities of the muscles and has no other meaning to it. Uh, Muscular dystrophy is genetic myopathy is usually caused by disturbance of structural protein or enzymes, resulting in necrosis of the muscle fibers and replacement by adipose and connective tissue. Myositis, it implies an autoimmune or infectious disorder in which the muscle histology shows an inflammatory response. Myotonia, it's the occurrence of the involuntary persistent muscle activity accompanied by the abnormal repetitive electrical discharge that distorts the normal contractile process. Uh, what are our goals while approaching the myopathies? The first goal is evaluating a patient with the suspected muscle disorder is to determine where the site of lesion is. The second goal is to determine the cause of myopathy. Finally, the third goal is to determine whether the therapy is available. If not, how to optimally manage the patient symptoms in order to maximize the quality of the life. The broad classification of myopathies, we can divide them into hereditary and acquired. In hereditary, we have congenital myopathies, channelopathies, mitochondrial myopathies, metabolic myopathies, muscular dystrophies, myotonic myopathies. Whereas in acquired, we have drug-induced myopathies, endocrine myopathies, toxic myopathies, inflammatory or immune myopathies, and myopathies with systemic illnesses. So when we clinically evaluate a patient of myopathy, we need to ask these six questions: whether there are any positive and negative symptoms present, what is the temporal evolution of the disease, what is the distribution of the weakness, that is a pattern of what kind of pattern of weakness patient has, and what are the precipitating factors, associated signs and symptoms, and the family history. So what are the negative and positive symptoms does the patient experience? The negative symptoms being exercise intolerance, fatigue, muscle atrophy, and weakness, whereas the positive symptoms are cramps, contractures, muscle hypertrophy, myalgia, myoglobinuria, and stiffness. Coming to the first weakness, so most common symptoms which patient presents to us with the usually the upper extremity weakness. Usually the patient presents with the proximal muscle weakness. The in upper extremity, the patient comes with a history of difficulty in brushing the teeth, difficulty in combing hair, trouble lifting the objects which are kept overhead, uh, and lower extremity weakness, difficulty rising from a low chair or a toilet, difficulty getting up from squatted position, and difficulty in climbing stairs. uh, as I told, like it suggests the proximal muscle weakness, which is the most common pattern in myopathies. The distal muscle involvement, which is less common, the patient would complain of difficulty in turning a key, difficulty in opening jars, and gaits instability due to food drop. The cranial muscle weakness, the patient may have slurred speech, difficulty swallowing, ptosis, and double vision. Fatigue. Fatigue is a very non-specific symptoms. It may occur as a patient's overall health condition, cardiopulmonary status, and emotional state and sleeping habits. However, certain metabolic and mitochondrial myopathies can cause abnormal fatigability after exercise. However, it is important for us to define the intensity and duration of the exercise that provoke the fatigue. Uh, right. This one is patients with McArdle syndrome. They experience this typical phenomenon called second wind phenomenon. Usually, for the first few minutes, the patient has severe fatigue and muscle pain and tachycardia due to inability of to break down the glycogen. However, after 8 to 10 minutes, symptoms usually improves as the muscle switch from blood-borne glucose to and utilization of the fatty acids. Uh, this is the characteristics of Macardle's disease. When we say fatigue, there is one more term which comes as a fatigability, which is a pathological fatigability. So, how do we differentiate between the term fatigue and fatigability, pathological fatigability? So, fatigue is a subjective symptoms of tiredness or low energy, whereas the fatigability is the objective decline in the performance with repeated activity. Uh, Usually, patients describe the fatigue as I feel tired. However, the fatigability, they say that the muscles gets weaker as there is a repeated use of the muscles, as in combing the hair, like climbing stairs, or eyes will droop by the evening or straining. Uh, and how do we quantify it? How do we measure it? Usually, fatigue is, since it's a symptom based, we cannot quantify it. However, fatigability might show some decremental response on RNS. And how what are the related the fatigue is related to the central factors like sleep, depression, systemic illness, whereas the fatigability might have a uh, neuromuscular junction or muscle physiology. Typically seen in depression, the fatigue is typically seen in depression, chronic fatigue syndrome, anemia, systemic illness, whereas fatigability in myasthenia gravis, neuromuscular, other neuromuscular disorders, and myopathies. Does fatigability improves with rest? It is variable because since it's a symptom-based phenomenology, whereas the fatigability it typically improves with the rest. Again, worsening with the activity, fatigability always worsens with the activity. Objective weakness will be present in fatigability. Coming to the next symptom, like fatigue is again another non-specific symptom of some myopathies. Maybe episodic, such as in some metabolic myopathies like myodenylate deaminase MAD deficiency or mitochondrial myopathies. Or it can be constant, such as in inflammatory muscle disorders. However, the muscle pain is not most common symptom in the muscle disorders and likely to be due to the fibromyalgia or myofascial pain. So, since the patient comes with the non-specific symptoms, how do we, since the fibromyalgia and myofascial pain are most common, how do we differentiate them from the muscle disease myalgia? So the characteristics of the pain in muscle disease usually be deep and aching type, which is diffuse, whereas the myofascial pain it will be localized with the trigger points, and fibromyalgia, as we know, it will be widespread and chronic aching. The distribution usually the muscle disorders will be proximal or symmetrical, whereas the myofascial pain, the focal region or the regional pain where the involvement of the inflammation is there, whereas fibromyalgia usually be diffuse and bilateral. Weakness, it will be in muscle disorders, it will be true weakness. Whereas in myofascial pain, it will be only a pain limited weakness. Whereas in fibromyalgia, there is no true weakness at all. Tenderness, the usually in muscle disorders, it will be mild or absent. However, in case of inflammatory myopathies, it can be moderate to severe also. But usually, in most of the myopathies, it will be mild or absent. Whereas myofascial pain, it will be discretely tender and there will be trigger points. Whereas in fibromyalgia, there will be multiple tender points as we take so many tender points as the clinical criteria for fibromyalgia. Uh, CPK levels are often elevated in muscle disorders, whereas they'll be normal in myofascial and fibromyalgia. EMG will show myopathic changes, whereas myofascial and fibromyalgia will be normal. And the imaging wise, like in MRI, it may show some muscle edema or inflammation, whereas in myofascial there might be some local strain or tight bands. And fibromyalgia, it will be normal. The associated features will be fatigability and exercise intolerance in muscle diseases, whereas it will be muscle tightness and decreased range of movements in myofascial pain. And in fibromyalgia, it will be sleep issues, fatigue, and the patient will have cognitive fog. Metabolic. Muscle disorder. Yes. Yes. Some of the common muscle diseases associated with myalgia are dyspherinopathies, we have Becker's dystrophic variant, inflammatory myopathies like dermatomyositis and polymyositis, hypothyroid myopathies, infectious myositis, especially the viral due to viral illnesses, tubular aggregate myopathy, mitochondrial myopathies, myodylic deaminase deficiency, toxic myopathy secondary to statins and chloroquines, and eosinophilic myalgia syndrome. Next symptom will be muscle cramp. They are typically benign, occurring frequently in normal individuals. Even some of us would have experienced muscle cramps in one or other way, which are seldom features of primary myopathy. It can occur with dehydration, the dyselectrolemias like hyponatremia, hypocalcemia, or hypercalcemia, and azotemias, mixed edema secondary to uncontrolled hypothyroidism, and disorders of the motor neurons, like especially the ALS. uh, Muscle contractures. Muscle contractures. This is a uncommon this one, but there are certain muscle disorders where the contractures are known. They are typically provoked by the exercise in patients with glycolytic enzyme defects. Contractures differ from cramps in that they usually last longer and electrically silent with needle EMG. Cramps are characterized by rapidly firing motor unit discharge on needle EMG. Uh, this is the hand contracture, which is there in Bethlehem's. My yes. Uh, okay. There is a list. Okay. Okay. Um, So when we talk about contractures, there are true contractures and pseudo contractures. Um in relevance to the myopathies, it is the true contractures are due to the fibrosis, fatty replacement, and permanent shortening, whereas pseudo contractures are due to pain, stiffness, myotonia, or inflammation. The passive range of movements are permanently reduced in muscle contractures and true contractures, whereas they improve with the relaxation or distractions in pseudo contractures. The the cause could be muscle fiber loss replaced by the collagen, whereas the pseudo contractures are by muscle spasm, myotonia, or painful guarding. The typical disorders associated with true contractures are Bethlehem's myopathy, EDMD, laminopathies, and calpainopathies, whereas the pseudocontractures are with metabolic myopathies, myotonic dystrophies, and inflammatory myopathies. On examining the muscle will be firm, tight, and shortened, whereas it will be normal or tense, but not truly shortened in case of pseudocontractures. In relation to activity, usually the true contractures are not activity dependent and they are fixed contractures, whereas the pseudo contractures they worsen with exercise or delayed relaxation. Pain usually absent in true contractures, whereas it is a common feature in the pseudo contractures. EMG may be normal or show myopathic changes, whereas the pseudo contractures will have myotonic discharges or irritability might be there. Reversibility usually poor and requires surgery, whereas the pseudocontractures often reversible with treatment of the underlying cause. And a key clinical clue persists with under anesthesia and resolves improves. Yeah. Internet. This this from internet. From internet not not from the article. Yes. 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 Pathway. Yes. 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 Okay. 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 This is the hand contracture in Bethlehem's myopathy and the elbow contracture in EDMD. With uh, uh, in calpanopathy, there might be the ankle contractures. This is again one slide which is, as ma'am told, the myopathies with the muscle contractures mainly secondary to the glycogen storage disorders, like the different types are like myophosphorylase deficiencies like Macardal syndrome, phosphofructokinase deficiency, phosphoglycerate kinase deficiency, phosphoglycerate mutase deficiency, lactate dehydrogenase deficiency, debrancher enzyme deficiency, hypothyroid myopathy, paramyotonia congenita, and crippling muscle disease. Lastly, the rare ones are Brody disease, which is mutation in ATP2A1 gene with autosomal recessive inheritance. Coming to the term myotonia. The myotonia is a phenomenon of impaired relaxation of the muscle after forceful voluntary contraction. It's due to the repetitive depolarization of the muscle membrane. Patient may complain of muscle stiffness or tightness, resulting in difficulty releasing their hand grip after a handshake, unscrewing a bottle cap, or opening their eyelids if they forcefully shut their eyes. Most commonly involves the hands and the eyelids. Where in lower limbs, they also have a tendency to trip and fall while trying to walk after sitting for a long time. Like, for example, they're waiting for a bus in the bus stand, and suddenly when they wake up and they tip to tend to trip and fall. Myotonia classically is worsened by cold and improves with the exercise. Uh, this is the one of the example showing hand, and this is the tongue myotonia, and this is the leg myotonia. Uh, Paramyotonia is a paradoxical myotonia, and the symptom that it is contraction, exposure to and paramyotonia. This is the differentiated table I have here. The myotonia and paramyotonia, the definition of myotonia will be delayed relaxation improving with repeated activity, whereas paramyotonia, delayed relaxation worsening with repeated activity or cold. The warm-up phenomenon usually that indicates that with the use, the myotonia the improves, whereas the paramyotonia worsens with use. The cold sensitivity has a minimal effect, whereas in myotonia, whereas it has a marked worsening in cold in paramyotonia. Uh, the clinical features will be grip or percussion myotonia, stiffness improving with activity, whereas in paramyotonia, it's a paradoxical myotonia. Usually, facial or eyelid stiffness is more common, whereas in the myotonia, it is more of limbs which is getting involved. Weakness is usually mild or improves with the repeated contractions in myotonia, whereas paramyotonia may develop fixed weakness after the episodes. Common causes are for myotonia, we have dystrophic and non-dystrophic causes. Dystrophic, we have myotonic dystrophic type 1 and type 2, and non-dystrophic, we have myotonia congenita, which is secondary to the chloride channel mutation. Whereas paramyotonia is secondary to the sodium channel mutation. EMG findings, we have classical myotonic discharges, whereas paramyotonia, myotonic discharges plus worsening after cooling. Uh, since like to mention here about channelopathies, we have the hypokalemic periodic paralysis, thyrotoxic periodic paralysis, hyperkalemic periodic paralysis, myotonia congenita, paramyotonia congenita, and Anderson-Tawil syndrome. And these are the some of the common channelopathies. The hypokalemic periodic paralysis is second. We have type 1 and type 2. Most common is type 1, which is secondary to the calcium channel mutation and which is autosomal dominant. The key clinical features will be the onset is in adolescence. Males are usually affected more than females and is triggered by high carb diet or salt meals and rest after exercise. It usually has a proximal weakness and arrhythmias. The thyrotoxicosis usually do not have any genetic cause, which is secondary to the hyperthyroidism, and it's common in Asian men and occur with hyperthyroidism. Hyperkalemic periodic paralysis is secondary to the sodium channel, which is SC14A mutation. It is also autosomal dominant, and it is a childhood onset. It's triggered by potassium rich diet and fasting, rest after exercise. It is also has a proximal weakness, and myotonia can also be possible. Myotonia, which is as already mentioned earlier, which worsens, improves with the activities worsens in cold. We have two autosomal dominant and autosomal recessive. Autosomal dominant is Thompson and Becker. And paramyotonia, as mentioned earlier, it is sodium channelopathy. Then Anderson-Tawil is a potassium channel due to the potassium channel mutation. It has a typical triad of periodic paralysis, arrhythmias, and the dysmorphic phases. Yes, usually periodic paralysis. Right. Uh, Coming to the red or cola colored urine, that is myoglobinuria. It's an uncommon manifestation of the muscle disease. It's caused by the excessive release of the myoglobin from the muscle during the periods of rapid muscle destruction, that is rhabdomyolysis. If patient complaints of exercise induced weakness and myalgias, they should be asked if their urine has ever turned cola colored or red colored after these episodes. Recurrent myoglobinuria is due to an underlying metabolic myopathy. Isolated episodes, particularly occurring after unaccustomed strenuous exercise, are usually uh, idiopathic. The causes of myoglobinuria, we can divide them into related to exercise and not related to exercise. The related to exercise is couch potato syndrome. Usually, a sedentary, obese person suddenly going for a gym, there will be a lot of excessive breakdown of myoglobin, and which will be causing myoglobinuria. Then we have McArdle's disease is glycogen storage disorder, and the lipid disorders like CPT deficiency. Then not related exercise usually are central non-neuromuscular causes, neuroleptic malignant syndrome, status epilepticus, drugs or toxins, malignant hyperthermia, polymyositis or dermatomyositis are rarely causing it, and viral or bacterial illnesses can also cause myoglobinuria. So next will be the temporal evolution of the disease. So what do you mean by temporal evolution? It's the time of onset of the symptoms and the rate of disease progression, whether it is acute, subacute, or chronic. And disease course will be whether it is progressive versus static, episodic, or monophasic versus relapsing. Uh, okay. Okay. So myopathies which are presenting at birth are usually we divide them into inherited and acquired causes. The inherited causes being glycogen storage disorders, that's acid maltase, phosphorylase deficiencies, lipid storage disorders like carnitine deficiency, then central core disease, myotubular myopathies, congenital fiber type disproportion, congenital muscular dystrophies, congenital myotonic dystrophies, muscular dystrophies, Nimalin, that is rod myopathy. Acquired, we have neonatal autoimmune myopathies, drug-induced neonatal weakness, could be due to maternal magnesium, anesthetic agents, birth asphyxia-related myopathy, and related to torch infection. Myopathies presenting in childhood, we divide them into muscular dystrophies, inflammatory myopathies, congenital myopathies, metabolic myopathies, then mitochondrial myopathies and endocrine metabolic myopathies. The muscular dystrophies we have Duchenne's, Becker's, Emery-Dreifuss, scapulohumeral, and limb-girdle. The inflammatory myopathies, the dermatomyositis is common, whereas polymyositis is rarely can present during in childhood also. The congenital myopathies, we have animalin, central nuclear and central core. Metabolic myopathies, lipid storage disorders like carnitine, and again glycogen storage is acid maltase deficiency. Then mitochondrial myopathies and the endocrine metabolic disorders are hypokalemia, hypercalcemia, and hypocalcemia. The myopathies presenting in adulthood, we divide them into 18 to 40 years and more than 40 years. The uh, uh, again dividing into inherited and acquired. Um, in 18 to 40 years of age, the inherited causes being Becker's myopathy, myotonic dystrophy, LGMD, EDMD, FSHDs, and metabolic myopathies like McArdle's and CPT2, CPT, or mitochondrial, and again channelopathies. The acquired causes are polymyositis, dermatomyositis, immune-mediated IMNM, and endocrine myopathies and toxic myopathies. Whereas more than 40 years, the late onset Pompe's can present, a late LGMD variant, the mild or late FSHD, and myotonic dystrophy type 2 can also present in the more than 40 years. Whereas the late onset usually they're more commonly acquired compared to the inherited, and the it's other way around for the 18 to 40 years. Whereas in for more than 40 years, the acquired causes being inclusion body myositis, dermatomyositis with the, carrying the malignancy risk, the immune-mediated necrotizing myopathies, the statin myopathies, hypothyroid myopathies, and paraneoplastic myopathies. The episodic weakness, episodic periods of weakness with normal strength interictally will be periodic paralysis, metabolic myopathies due to certain glycolytic pathways. The constant weakness, we have acute or subacute progression. It's the common example is inflammatory myopathies, that is dermatomyositis or polymyositis. Whereas chronic slow progression over years, most of the muscular dystrophies are chronic slow progressing over year. Even IBM can also have a chronic slow progression. Whereas non-progressive weakness with a little change over decades is is the congenital myopathies. Uh, Monophasic or relapsing polymyositis can occasionally have an acute monophasic course with a complete resolution of strength within weeks or months. Then a patient with acute rhabdomyolysis due to cocaine may have just a single episode. Patients with periodic paralysis or metabolic myopathies can have a recurrent attacks of weakness over many years. Coming to the next question, we ask the distribution of weakness. This is uh, the pattern of weakness. This is the most common. This one we where we identify the kind of pattern where we attribute to the kind of muscle disorder. So coming to the first pattern, we have proximal, which is a limb girdle weakness. It's the most common pattern of muscle weaknesses in myopathies. It's symmetrical weakness affecting predominantly the proximal muscles of the legs and arms. The distal muscles are usually involved, but not to usually to a lesser extent. Neck extensor and flexor muscles are also frequently involved. This pattern of weakness is seen most in most hereditary and acquired myopathies, and therefore it is least specific in arriving the particular diagnosis. The common examples of proximal, the pattern one is limb girdle muscular dystrophy, DMD, Becker's myotonic dystrophy type 2, and inflammatory myopathies. This is the image showing DMD, where usually there is a fast progression that by the age of 5 years there will be progressive muscle weakness, and by the age of 12 years there will be wheelchair bound, and later the respiratory and cardiac complications sets in, and which will lead to the mortality. Then this is another picture showing myotonic dystrophies where there is typical phases of there is a hatchet faces with a frontal balding, and there is a cataract and a gynecomastia. By usually around 20 years. Yes. Okay. Pattern two is distal weakness. This pattern of weakness predominantly involves the distal muscle of the upper or lower extremities, the anterior or posterior compartment muscle groups. The involvement is usually, although not invariably, symmetrical. It's a more commonly a feature of neuropathies. So, how do we, when such situation arises, how do we differentiate between whether it is a myopathy or neuropathies? Usually, there will be hardcore sense of neuropathies, like there will be abnormalities of the reflexes, whereas the myopathies usually do not have any abnormalities of the reflexes. Then the tone will be usually abnormal in the neuropathies, whereas the myopathies it might be preserved. The causes of the pattern to distal weakness is the distal myopathies. We have late onset type 1, that is Willander. Late adult onset type 2 is Marksburg or Wood, and early adult onset Nonaka, Miyoshi, Liang, and Desmin myopathy. Childhood onset distal myopathy is another distal myopathy, and myotonic dystrophies is type 1 and type 2. Inclusion body myositis, that is sporadic IBM. Metabolic myopathies, deep branch deficiency, and acid maltase deficiency. Congenital myopathies can also present with distal weakness, that is pneumonal myopathy, central core myopathy, and centronuclear myopathy. The next pattern is proximal arm and distal leg weakness. This pattern of weakness affects the periscapular muscles of the proximal arm and the anterior compartments of the muscles of the distal lower extremity, that is the scapuloperoneal distribution. The scapular muscle weakness is usually characterized by scapular winking, and weakness can be very asymmetrical. The common examples of this one is scapuloperoneal dystrophy, emerodrophis dystrophies, and certain LGMDs. Congenital myopathies, like when this type of pattern is associated with the facial involvement, FSHD, which is again a most common cause of this kind of a pattern, and other congenital myopathies can also have this pattern. This is the figure showing the uh, FSHD, where there is a biceps or triceps are involved. This with the sparing of the deltoid. Then there might be like there is a facial involvement. Then there is scapular winging. Then lordosis with the presence of beaver sign, and the anterior the ankle dorsiflexion being impaired. Then this is the picture of EDMD showing the proximal arm and the distal, where there is a soleus and gastrocnemius is atrophied. Uh, the pattern 4 is distal arm and proximal leg weakness. This pattern is associated with distal arm weakness involving the distal forearm of the forearm muscle, that is wrist and finger flexors, and the proximal leg weakness involving the knee extensor. As we know, this is a classic example of IBMs, inclusion body myositis. Usually, in this, the facial muscles are spared, and the weakness is often asymmetrical between the two sides, which is uncommon in most myopathies. So, this pattern is pathogram of inclusion body myositis. Uh, However, may also represent an uncommon presentation of myotonic dystrophy. However, unlike in IBM, the muscle weakness is usually symmetrical. So, IBM will be usually asymmetrical presentation. So this is the picture showing the distal arm, the forearm being wasted, and the quadriceps being atrophied here. The next pattern is ptosis with or without ophthalmoplegia. Usually, although not always, occurs with the without the symptoms of diplopia. Uh, Facial weakness, which is against like usually when we say that a patient presenting with ptosis, like in myasthenia gravis syndrome, there might be some symptom of diplopia, whereas here in muscle disorders, usually they present without the symptom of diplopia. Facial weakness is uncommon. Extremity weakness is extremely variable depending on the diagnosis. Based on the combination, the of ptosis, ophthalmoplegia, and dysphagia, it should suggest the ocular OPMD, that is oculopharyngeal muscular dystrophy, whereas the ptosis and ophthalmoplegia with pharyngeal involvement is a hallmark of, sorry, without a prominent pharyngeal involvement is a hallmark of mitochondrial myopathies. Ptosis and facial weakness without ophthalmoplegia is pointing towards myotonic dystrophy.
ഇന്ന് മാഡം 2 ദിവസം എടുത്തിരിക്കുക
Yeah.
അത് വൈകുന്നേരം
Why there? Yes, 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 yes. Those are the classic examples, as I already mentioned, but these are the other, this one, those without ophthalmoplegia, again, myotonic dystrophy, congenital myopathies, and then myofibrillar myopathies. Ptosis without ophthalmoplegia will be OPMDs, then mitochondrial and neuromuscular diseases. Uh, this picture showing the ophthalmo, the ptosis with ophthalmoporosis due to the inherited myopathies. Next will be a prominent neck. The next pattern is a prominent neck extensor weakness. It's called as dropped head syndrome. Involvement of the neck flexor is variable. Isolated neck extension weakness represents a distinct muscle disorder called isolated neck extensor myopathy. So prominent neck extensor weakness is commonly seen with amyotrophic lateral sclerosis and myasthenia gravis, usually, whereas uh, the myopathies with prominent neck extensor weakness are isolated neck extensor myopathy, polymyositis, dermatomyositis, inclusion body myositis, carnitine deficiency, FSHD, myotonic dystrophy, congenital myopathy, and hyperparathyroidism can also have the prominent neck extensor weakness. Map in certain map AVM. Yes. Next pattern is bulbar weakness. It's manifested by symptom of dysarthria and dysphagia. While number of myopathies can have a bulbar involvement, the muscular dystrophy that has a bulbar involvement as a primary manifestation is OPMD. The LGMD type 1A, that is myotillopathy, can present with the isolated bulbar weakness, and the inflammatory myopathies may rarely present in this manner. Uh, Neuromuscular junction disorders such as myasthenia gravis and Lambert-Eaton syndrome also frequently have bulbar symptoms and signs. This pattern is considered an overlap with the ALS and other motor neuron diseases that can have a significant bulbar involvement. Basically, it's OPMD and LGMD type 1A in myopathies, which has the uh, myopathies related bulbar weakness. This is again the repetition slide. Whereas, like usually, the myopathy is presenting with the myoglobinurias, again related to exercise and non-related to exercise. Pattern 9 is episodic weakness, delayed or unrelated to the exercise. Is We have periodic paralysis that is due to calcium channelopathies, that is hypokalemia, and sodium channelopathies, it's hyperkalemia, and Anderson-Tawil, secondary periodic paralysis secondary to the thyrotoxicosis. And apart from as mentioned, like we did not mention this in channelopathies, that other cause of episodic weakness, which is maybe unrelated to exercise, is neuromuscular. The episodic weakness is neuromuscular junction disease. This is again stiffness or decreased ability to relax. That is improving with exercise is myotonia. Uh, Worsen with exercise or cold sensitivity is paramyotonia. Then with fixed weakness, we have myotonic dystrophy. So next will be what are the precipitating factors. The precipitating factors are medications. The weakness, pain, and episodic weakness with a fever is will point towards the carnitine palmital transferase deficiency. Whereas patients with paramyotonia congenita frequently report that cold exposure may precipitate their symptom of nasal stiffness. Uh, Certain drugs causing toxic myopathies. We have non-inflammatory necrotizing or vacuolar pattern, rhabdomyolysis and myoglobinuria, inflammatory and myosin loss. The non-inflammatory necrotizing pattern will be due to the alcohol, cholesterol lowering agents like statins, then chloroquine, colchicine, cyclosporin and tacrolimus, emitin. Uh, then we have vitamin A analogs, labetalol, vincristine. Then rhabdomyolysis and myoglobinuria with secondary to alcohol, cocaine, amphetamine, heroin, toluene. Then inflammatory, we have secondary to cimetidine, D-penicillamine, L-tryptophan, procainamide, and sometimes even L-dopa. Myosin loss, uh, we have non-depolarizing neuromuscular blocking agents and steroids. Coming to the associated signs and symptoms, uh, major things what we should be considering is one is cardiac and the respiratory involvement. The cardiac involvement, the arrhythmias usually are common with the metabolic myopathies, Kearns-Sayre syndrome, Anderson-Tawil, polymyositis, muscular dystrophies like myotonic dystrophy, limb girdle, and emerid diffuse. And rest are. Uh, congestive heart failure, the patients of DMD, Becker's, emerid diffuse, myotonic dystrophy can also cause then limb girdle, nimalin, acid maltase, carnitis, and polymyositis. The early respiratory insufficiency in adults, the Pompey's, this is the first diagnosed. This picture is a first person who was diagnosed as a Pompey's disease in India, who was recently died. Then Pompey's disease, myopathies with the myofibrillar pathology as early respiratory insufficiency, congenital myopathies, especially multiminicore disease. Then we have a myotonic dystrophy type 1 can also have early respiratory involvement, and mitochondrial myopathies. Then the additional extraskeletal manifestations like the brain MRI abnormalities can be seen in alpha dystroglycanopathies, LAMA2 muscular dystrophies, myotonic dystrophies, mitochondrial disorders. Cataract, as we know, the most common is myotonic dystrophies. And can also be seen in alpha beta crystallopathies, mitochondrial disorders, then dynaminopathies. Gonadal insufficiency, again, it's more common in myotonic dystrophies and mitochondrial disorders. Retinal vascular diseases, FSHDs, then ALS, frontotemporal dementia, and Paget disease, which is associated with myopathies with the rimmed vacuoles, multisystem as a part of multisystem proteinopathy. Then acquired, we have arthritis, which is an interstitial lung disease, could be associated with antisynthetase syndrome. Then the malignancies, this immune-mediated IMNM and myositis. Certain overlapping myopathies and neuromuscular transmissions are muscular dystrophies, congenital myopathy, desminopathy, sodium channelopathies, and glycosylation defects. These are the genes involved in it. Then inherited myopathies associated with peripheral neuropathies. So, like the myofibrillar myopathies, centronuclear myopathies, they can also have some part of peripheral nerve involvement. So the common examples are myofibrillar, which has a peripheral neuropathy, axonal sensory motor with or without giant axons. Then centronuclear, which has the Charcot-Marie-Tooth. This is type 2. Charcot-Marie-Tooth disease with the dominant intermediate B. And mitochondrial, it could have the peripheral neuropathy, which is often axonal type. And lipid storage, the peripheral neuropathies and sensory neuropathy can be associated. Then glycogen storage, we have peripheral neuropathy and sensory motor neuropathy. Next is the family history. The a thorough family history is of a great importance. Uh, we have to ask whether any of the members were wheelchair bound, any skeletal deformities were there, functional limitations are usually more informative than just a question of does the patient have any family members have a muscle disorder. So diagnosis, the myopathies based on the inheritance, we have X-linked, autosomal dominant, autosomal recessive, and maternal transmission. The autosomal dominant, X-linked are classical Duchenne's and Becker's, and EDMD is also X-linked. And then autosomal dominant are FSHDs, limb girdle, OPMDs, myotonic dystrophies, all the periodic paralysis, paramyotonia congenita, which is, and the in myotonia congenita, the Thompson is autosomal dominant, whereas the Becker is autosomal recessive, and the central core myopathies. The autosomal recessives are again a certain type of limb girdle and to the diagnosis. This is the picture of congenital myopathies where there is a elongated faces with the high arched palate and rigid spine. And this is the picture of Anderson Tawil where there is low set ears, hypoplastic mandible, clinodactyl, and there will be short stature and scoliosis. The elbow contractures, as previously shown, it's common in emerit diffuse. Then epidermis bullosa complex is common with the plectin muscular dystrophies. Frontal balding, as myotonic dystrophy is the more common. It's common with myotonic dystrophy. Hanging big toe, it's congenital myopathies of MYH7, NB, and MYPN. Then hearing loss, as we know, it is more common with the mitochondrial disorders, and FSHD can also have the hearing loss. Keloids, collagen 6 muscular dystrophy, that is Bethlehem's myopathy. Then low set optic atrophy, retinitis pigmentosa are common with mitochondrial disorders. Malignant hyperthermia, that is common with R1 and the calcium channel myopathies. Sudden cardiac death in the family, the LMNA muscular dystrophy, and early cataract with myotonic dystrophy. Then the acquired myopathies, we have the classical skin rash of Gautrans, papules, and heliotropic rash, shawl or V sign in dermatomyositis. This is a mechanic hand in the antisynthetase syndrome, and purpura can be seen in vasculitic myopathies. Coming to the laboratory test, uh, the elevated creatinine kinase suggests the myopathies if taken in the right clinical context. CK is elevated in many muscular dystrophies, but normal in many inherited myopathies, including some of the muscular dystrophies. CK can be normal in patients with myositis, inflammatory reactions predominantly affecting the muscle interstitium, sparing the muscle fibers. That is uh, dermatomyositis, antisynthetase syndrome, vasculitic myopathy. Therefore, in these myopathies, it's not a good marker of disease activity or response to treatment. Based on the level of elevation of the CK, we can divide them into mild, moderate, high, and very high. The mild, it could be non-specific elevation that is less than 1000, could be secondary to exercise, statins, and drugs, hypothyroidism, certain neuropathies and carrier states, and idiopathic hyper elevated CK levels. Uh, Moderate, that is 1000 to 5000, and that usually suggests the myopathic process. So usually are all the myopathies usually fall under this criteria, uh, that is inflammatory myopathies, muscular dystrophies, metabolic myopathies, and endocrine myopathies. Whereas usually high levels, that is 5000 to 20,000, significant muscle injury due to there is rhabdomyolysis, severe inflammatory myopathies, then metabolic crisis, or very high levels, that is more than usually 20,000, severe necrosis and risk of renal failure, with fulminant rhabdomyolysis, crush injury, heat stroke, severe necrotizing myopathies. Yes, yes. Distance. Dystrophinopathies or dystrophinopathies. Uh, then aldolase and lactate dehydrogenase are not a good indicator of myopathy as these enzymes are present in muscle tissue and the liver. However, aldolase levels can increase in the setting of an interstitial inflammatory reaction despite the normal CK. AST, ALT are usually present in both liver and muscle. Normal GGT in patients with elevated CK, AST, ALT points away from the hepatic source. The again measurement of the our electrolytes, renal functions would as a part of laboratory evaluation of myopathy should be considered. as these abnormalities again can cause or they may worsen the weakness. Additionally, abnormal high levels of potassium in the setting of episodic weakness may indicate the periodic paralysis. Uh, Measurement of the acid alpha glucosidase in the right blood spot uh, would indicate the Pompe's disease. Then abnormal plasma acyl carnitine profile in the presence of the abnormal organic acids in urine, it points towards the MAD. Then persistently or intermittently elevated blood levels could be part of mitochondrial disorder, but normal levels does not exclude the mitochondrial disorder. The certain hematological abnormalities associated with inherited myopathies. Uh, Neutropenia is associated with centronuclear and Bach syndrome. Hemolytic trait or anemia, uh, phosphofructokinase deficiency, aldolase A deficiency, phosphoglycerate kinase deficiency, uh, triose phosphate isomerase deficiency. Sideroblastic anemia is common in mitochondrial myopathies or disorders. Uh, Megaloblastic anemia, mitochondrial myopathy with megaloblastic anemia. Then eosinophilia is common with the calpainopathy. Thrombocytopenia is common with myopathies with the tubular aggregates and GNE myopathy. Jordan anomaly is common with the neutral lipid storage disorders. And acanthocytes, as we know, it is common with the McLeod syndrome. Electrodiagnostic studies, needle EMG may be normal to having a severe hallmark features. At rest, the abnormal spontaneous activity can include the myotonic discharges, fibrillation potentials, or both. Myotonic discharges may indicate a myotonic disorder, including the myotonic dystrophy. The electrical myotonia can also be seen in the non-myotonic disorders. The seen in immune-mediated necrotizing myopathy, Pompe's disease, toxic myopathies, critical illness neuropathies, uh, and myopathies with the protein aggregates or other structural abnormalities like Nemaline rods. Needle EMG examination, the motor units, we do a brief duration, small amplitude, and early recruitment. The low frequency, the repetitive nerve stimulation may help us to differentiate between the neuromuscular disorder and the myopathy. However, pathogenic variants in certain genes can cause myopathy, congenital myasthenic syndrome, or even both. So, one of the this one is mild pathological myopathic changes can occur in the muscle patients with DOX7 and COL13A1 congenital myasthenic syndromes. Then coming to the myositis antibody panel, uh, as we know, like we have in mainly these are for the inflammatory to MDA5. Okay. Uh, Muscle biopsy, the selection of the appropriate muscle is critical. Usually, we take the power of it should be at least power of 4. That should be biopsied. If it is lesser than that, the result uh, uh, should the less than that shouldn't be biopsied, as should show may show the end stage muscle disease. The muscle of choice is usually biceps and vastus lateralis. The gastrocnemius should be avoided since its tendon is inserted. Uh, Insertion extends throughout the muscle, and inadvertent sampling of the myotendinous junction may cause inability with the interpretation. Typical myopathic patterns include the central nuclei, both small and large hypertrophic round fibers, split fibers, degenerating and regenerating fibers, and chronic myopathies frequently show evidence of increased connective tissue and fat. Uh, this is the few pattern of diffuse pattern dystrophy. This is the pattern of seen in focal pattern, which is in this is in the Yes, I, yes, yes. Good, but, okay. Atrophy and hypertrophy. Muscle edema and fatty replacement through T1 weighted and T2 weighted fat suppressed or still sequences. It can also be helpful to assess the disease progression naturally. This is the image showing the in dermatomyositis and in the thigh muscle where there is uh, along the facial layer, especially in this is the the star is the quadriceps and the arrow which is showed here is biceps. Uh, then the last one is uh, shows no significant abnormalities. This is a normal image. Genetics studies, we have whole exome, next generation sequencing, and then we have the uh, repeat expansions. Uh, so the whole exome and or the next generation sequencing, usually the disorders, the genes and associated myopathies are the RYR1 is central core multimini core, and ACTA1A is numalin. NEB gene is with then repeat expansion is with the mitotic dystrophies type 1 and type 2. That will be your DMPK gene with the CTG expansion. Then with the Fragile X, it is CGG expansion. This is the again. Yes. In summary, like the intense is the one any myopathy is uh, proximal limb girdle pattern. So most myopathies usually present with this kind of pattern. However, the whenever the patient presents with other patterns, we should be able to recognize. Say, for example, like as we know in there is a proximal leg and distal arm involvement. It is classical for inclusion body myositis, whereas it can be seen in sometimes in myotonic dystrophies also, but it's a very classical for our inclusion body myositis. Whereas the scapuloperoneal pattern, which is again distal arm and proximal arm and the distal leg is FSHDs and EMDs and this one. Then whenever the where ma'am? It a muscle disease, abductor weakness. EM, EDM, yeah, FSHD, confused. FSHD.
So are there any doubts? So here actually you've given the basic outline of so there are many points also for the one is how to differentiate between a genetic versus an acquired myopathy. What are the points in clinical examination or history which will help you to differentiate like selectivity versus involvement? This is sources contracts. How many points to help to differentiate the genetic versus acquired disease? And over the years, several selective patterns to help you differentiate within the genetic disease as well. And there are a few corrections which will be something like complexes within the selectors wasn't that which is true. It is not the true compressor of versus compressor is actually due to the bipolar contraction where the average you can do it relaxation. Whereas a fibrous contraction is due to a fixed structural problem, which usually you cannot overcome or can be overcome only in the early phases. I think we have already exceeded time, so we will wind it up if there are no questions. Thank you.
Thank you for the patient list. We are winding up this session.